Grand Round dessa semana, nós devemos a duas pessoas aqui da Emergência, a Ana e o Márcio. Graças a ele, nós estamos trazendo a professora Vicki, que é a médica-chefe do Serviço de Emergência do Massachusetts General Hospital. Se vocês entrarem na internet, ela tem uma vasta publicação nessa área do ultrassom, que é uma área que a gente está engatinhando ainda, a emergência, anestesia, terapia intensiva, área da enfermagem, e eu acho que é uma nova estratégia de atendimento que deve crescer nos próximos anos, e tudo depende do nosso treinamento. Então, eu acho que essa apresentação hoje é de extrema importância nesse futuro próximo, que já é uma realidade. Nós temos vários ecógrafos já no hospital, a emergência, a CTI e a anestesia. E a gente quer trazer isso também para a área da enfermagem. Para dar as boas-vindas à professora, eu vou convidar a Ana, que estagiou com a professora Vicki no Massachusetts, e que faça a apresentação e as honrarias da nossa casa.
This is unexpected. Bom, para mim é um prazer imenso poder ter o grande round hoje e a professora Vicki junto com a gente. Como deve ser do conhecimento de todos, o ultrassom ele tem sido uma ferramenta muito importante no uso point of care, à beira do leito, como a gente tem usado, e ele aspira a ser, conforme for barateando o custo, substituir talvez o estetoscópio, e que a gente possa ter uma ferramenta de maior precisão para a gente poder atuar, sobretudo no cenário da emergência, onde a gente precisa ter o maior grau de certeza possível para tomar uma decisão. Então é com imenso prazer, mas imenso prazer, que eu apresento a Vicki para falar sobre a abordagem inicial do choque, e que seja um ótimo grande round. Se vocês puderem participar e tirarem dúvidas e perguntarem, eu acredito que ela vai gostar bastante. Please.
Well, I don't speak Portuguese, so I think that said now I can start my talk. But it's really, really nice to be here. You have a beautiful city. The flowers are incredible. We were driving around seeing all the beautiful trees, and the weather is very, very nice. In Boston right now it is snowing, so I'm very happy to be here in Porto Alegre and to be talking with you today about this. Ultrasound, as you will see, becomes somewhat of a passion for the people who get interested in it. And sometimes we think of ourselves a little bit like missionaries spreading ultrasound news across different countries. And you will see why in a few minutes, because the thing that's amazing about technology, when it is the right technology at the right time, is it's like a spark and it can start a fire, because it's like a desert. The trees and the branches just catch the fire, and it spreads almost faster than we can teach. And so I think when I show you some of the examples, you can imagine in your own practice how you would use this tool. And I'll try to make the case that it's an efficient tool, it's a cost-effective tool, and it's a helpful tool for the patients as well. So again, what we'll talk about today is what is point-of-care ultrasound, just to make sure we're very clear that this is not the same as what radiologists do. This is a different concept, a different idea of using diagnostic imaging, and so we have to be very clear about this. I'll talk a little bit about some of the basic ultrasound used in resuscitation, cardiac, thoracic, which I think is really important, and then some IVC assessments looking for fluid status, and then we'll talk about some cases. So the first thing to know about point-of-care ultrasound, using this ultrasound as a comprehensive evaluation looking for diagnoses. What you are doing when you use ultrasound in a point-of-care way is you are the doctor at the bedside, have a suspicion for some process. You are suspicious for a pneumothorax. You are suspicious for a pericardial effusion. You are suspicious that the heart is not beating well. And then you use the ultrasound to help augment that suspicion by looking inside the body. It's very similar, I think, to the same way we used a stethoscope. So when you're standing at the bedside, you already have an idea that the patient has CHF, or congestive heart failure, and then you use your stethoscope to listen for what you are suspicious for. It's the exact same idea and the same concept with point-of-care ultrasound. You're using it in a directed way, answering yes or no question. And my favorite thing is that point-of-care ultrasound shortens, which makes it sound very user-friendly. It's not something that should be frightening or overwhelming. It's something that should be very accessible. Our training in the United States has been around for years. And I think when we started training people, most radiologists and people who use diagnostic ultrasound in a comprehensive way couldn't imagine that this was enough training. And I can tell you, we've been doing this for 20 years now, and it is definitely not enough training for a lifetime, but is enough training to get started. Because the power of these images and the way you use them is exactly the same way you use, say, a D-dimer test. It's not the only test you do, but it helps to focus your exam and narrow your differential. And so I think this training is adequate to use the technology in that way. This is not obviously enough training to become a radiologist, but this is more than enough training to ask yes or no questions of the ultrasound that you are using. So this is one of my that Homer Simpson, as he imagines what is the perfect animal. It's something that can give you bacon, it can give you pork, it can give you sausage, it can do everything all at once. I think that ultrasound is this perfect animal. It's the perfect animal because it's portable, it's safe, you can do it many times. There's no restriction in how many times you look at a patient's heart. You can use it digitally so that you can use the images to transmit by wireless or by email, even on a cell phone. It's battery operated, so you can move the machines into very closed spaces in the ICU or in the emergency department. And most importantly, it's a multi-use machine, so your nurse can use the same machine to put in an IV that you use to look at the heart to decide if there's a pericardial effusion, that the OB uses to look and see if there's an ectopic pregnancy or a pregnancy. It's all the same machine. So for the administrators in the room, this means that it's very attractive because it's very cost effective. Many people can use the same technology for different uses, and that means that it becomes less and less of a cost as you're thinking about this in the future. So the idea, of course, the concept here is that in the traditional use of imaging, you have a patient who talks to a treating physician. That treating physician is worried about a diagnosis, so they order a test. Usually, at least in the United States, the patient goes to a technologist who performs the test, a CT or an ultrasound. That image is then transmitted to the radiologist. The radiologist looks at the test, talks to the treating physician, and at least in the United States, usually there's a differential that's about 5 things long, and then the last sentence says correlate clinically. So instead, why not have a test that can bring the patient and the treating clinician close together? Because now the patient and the doctor can talk to each other as they're looking at the pictures. And I can tell you, patients love ultrasound because they can see their heart, they can see their kidney, they can see what you're talking about. And actually, you know, no offense to anyone in the audience who spent many years studying imaging, but it's really, they can understand these pictures in a couple of minutes as you teach them and you show them the pathology. And not only that, the family of the patient also understands. And I think it improves compliance, it improves patient satisfaction, and also, this is a secret, but then the patient thinks you're very smart. And you may not be very smart, you may not be sure, but I can tell you that in the emergency department, I've had numerous people come in and say, we want that doctor who does the ultrasound, because it seems like you have some magic powers to do this and to show the patient. But really, it's just a very common exchange of information, and it just brings you back to the bedside, because now you are talking to the patient directly instead of talking to the radiologist and the technologist and the physician and the other people. You are talking directly to the patient. This is not something that's just specific. There was an article that was recently in the New England Journal of Medicine, and these are all the people. You don't need to see all the specifics, but this is the whole list of specialties that use point-of-care ultrasound. So this technology is not something that's just for the emergency department. This is a technology that's for the clinic, for the wards, for the ICU, for the ambulance, for the helicopter. This is a technology that can be used in all these different scenarios. And the beauty of it is everybody doesn't have to use it the same way. You can use it in the way that makes sense for you. If you are a nurse, you use it to look for a peripheral IV that you can place. If you're a doctor in the helicopter, you use it to look for a pneumothorax, and you use it in a specific way that you can identify. So this is my hospital. This is Mass General. As you can see, there's a lot of construction also in Mass. Hospitals are always in construction. It seems to me this is the case. But we use this in the ambulance, we use it in the ICU, we use it in the ward, and we use it in the emergency department. And it's really changed the way the doctors talk to each other within that system. So I'm assuming the pressures on the clinicians here in Brazil are the same as the pressures on the clinicians in the United States. Which is, time is always a problem. There's never enough time to do all the things that you're supposed to do in a day. We're always worried about where the patient is going to go, so how the patient is going to go to a floor, or an ICU, or to the OR. Cost is a very big issue in the United States. If you paid attention to our election at all we talked about was cost. And the outcomes. Of course, you want your outcomes to be improved. And I think in some ways with one machine you can do all these different tests, and I think that's the power. Again, just to reiterate that this is where point-of-care ultrasound really has a place, I think, not just within the hospital, within medical training. And what I think of it is usually we're looking for a needle in a haystack when we have a patient, and then with ultrasound the needle becomes very, very big. So just remember, if you remember nothing from my talk in my English, remember, and I think that will help. The other thing is the technology has changed so much in the last 50 years. So this is my favorite picture because this is the first ultrasound machine. And this poor patient had to get into a tub of water, and then he had to trust the doctors that they shoot electricity through this tub of water, that he would be safe. And some little pixels would show up on this plate, and somehow you could interpret that. Now we have these tiny machines that are a cell phone size. They have imaging capacity to send this wirelessly. You can use it at the bedside. You can send the pictures from 3G networks. And you can use digital imaging to help support and to use the analysis. I'll talk about this in a minute. But the digital support can help you analyze these pictures. So really the revolution in technology that's happened in the computer world is now transmitting to the ultrasound world, and I think it will make a big difference as we go forward. Okay, so that's to convince you in my evangelistic phase that this is a good idea. Now we'll talk a little bit about resuscitation. Any goals of resuscitation are first to identify the correct rhythm, second to identify any treatable causes, and then 3 to measure a response to therapy. And I'll try to make a case for you that ultrasound can help you in all of these. So the first question when you have someone who's in shock or in cardiac arrest is what is the underlying rhythm? And so why would you use ultrasound if you're trying to decide between asystole, PEA, or what's called pseudo-PEA, which is when your pulse is so faint that you can't feel it, but there is some ventricular contractility. So the first question, there are 2 papers that made a huge impact for emergency physicians in the United States. What these 2 papers show is that if patients are brought into the emergency department with cardiac arrest ongoing, so CPR has already started, when you look with the ultrasound, if there is no cardiac contractility, none of these patients survive. Now, this is not a surprise to many people who work in an ICU or work in the emergency department, but it makes a big difference, I think, mostly for families who are in the emergency department. It's very hard when the patient arrives to stop resuscitation, especially if the family is there, because they just got to the hospital. So they are expecting a miracle from you many times. And I think it's very helpful sometimes to show the people. Now, you have to be careful. You have to have no one bagging the patient, no one doing compressions while you're using the ultrasound. But if you can show people a still heart, it's a very powerful thing. And I think it helps bring the team and the family to a conclusion where it's more of a closure. The other problem with cardiac arrest and with is that we don't always make the right decision. So this was an interesting study published in 2010 where they looked at 100 patients with CPR ongoing. And before the ultrasound, the doctor had to decide if it was PEA or asystole, and you can see the numbers there. After the ultrasound, what happened was when they put the ultrasound on the heart, many times when they thought the heart was asystole or still, they could see ventricular contractions. And when they thought that there were ventricular contractions and they put the ultrasound on the heart, they could see that it was still. Now, how could this be? I can tell you that in the United States, the people who are standing at the bed feeling the pulse are usually the most junior doctors in the room. The senior doctor is the person who is leading the resuscitation and giving orders to the nurses and giving orders to the techs, and the most junior person is standing there feeling the pulse. Imagine the pressure that is, because every decision is made on whether they feel a pulse or not. And everyone is screaming at them, is there a pulse, is there a pulse? And half the time you say yes, and half the time you say no. And there's actually a study that looked at this. And what they just found was that when there is a pulse, people are very good at finding that pulse. They can feel the pulse. But when there is not a pulse, people are very unsure. It's a that they'll be right. And so what they do, I think, is they're not sure. They're afraid to say there's no pulse because that means a whole different kind of thing. And they guess, or they're not sure, or they can't say for definite. And so this study, I think, really helps because, as most of us know, when you have someone's in PEA, when there's ventricular contractions, you make a much bigger effort to resuscitate that patient and to look for other causes than you do when there's no contractions. And I think this is something that could really make a difference. There was a recent study that came out that showed that in-hospital arrests are probably called too soon, and that if you do CPR for the full ACLS 15 minutes, that you have better outcomes. And I think it's because we don't know always whether we're dealing with true asystole or people who have some ventricular contractility. And if we can look with the ultrasound to see that, I think we can be more specific in our resuscitations. The other thing is there are different causes of arrest, and I don't know if this can project to the back, but this on the right is a patient who's in asystole. You can see that the blood in the right ventricle here is already starting to clot. This is someone who has no cardiac contractility, and if this is somebody who's had 15 minutes of CPR, their outcomes are very, very poor. This patient, on the other hand, has a large amount of clot. I don't know if you can see this, but right here, this is the right ventricle, this is the left ventricle, this is the pericardium. Amount of clot in that pericardium. And in the right situation, this is somebody with recently, like minutes of lost circulation. If you open that pericardium and release that clot, you can actually make a big difference in their outcome. So knowing the difference between these two patients makes a very big change in what you do and how you resuscitate them. You would never know this without ultrasound, unless, you know, of course, they had a knife sticking out of their chest. Then maybe you would know. Okay, so first of all, we've talked about using ultrasound to correct underlying rhythm. The second thing you can use ultrasound for is to identify treatable causes. I already talked about one, which is looking for things within the heart or within the pericardium that are causing tamponade physiology. There are many different causes of treatable PEA, and many people have different mnemonics to remember all these things. But this list here is all diagnosable by ultrasound. And so if you have someone who's in shock, who is in a PEA rhythm, looking for a tension pneumothorax, looking for cardiogenic shock, a decreased contractility, looking for abdominal hemorrhage, looking for an ectopic pregnancy, looking for a AAA, all of these things are things you can see with ultrasound. So imagine how powerful you will feel if you're at the bedside and the patient is in shock and you can go through this algorithm by yourself at the bedside with these diagnoses in mind. So there are numerous resuscitation protocols. That if you are a budding researcher in this audience, you can make up a resuscitation protocol and get it published and become very famous. I think that there is evidence. I think FATE is the protocol that's been around the longest. It was Dr. Sloth, who is a doctor in Denmark. He's an intensive care unit doctor. And I think the protocols are slightly different between the intensive care unit and the emergency department because you don't know as much about the emergency department patients. But what he showed was that many times when you use ultrasound in the resuscitation, you make a change in what you're going to do or you stop doing something. So if there is no, when you look with ultrasound, do not waste time putting in a chest tube. If there is a pneumothorax, then obviously you want to put in a chest tube. And so these are the things, this is the only research that we have looking at the outcomes for these resuscitation protocols. So again, if there are any researchers and the residents who are here, this is a great area for research. I think in the emergency department, the best is called the RUSH protocol. And what that looks at is it looks at heart views. So again, deciding whether the heart is beating well, whether there's an effusion, whether the RV looks very blown out and as suggestive of a PE. Looks at the IVC to decide if it's flat or it's full as a proxy for volume status. Looks at Morrison's pouch in the FAST exam to see if there's bleeding within the abdominal cavity. Screens the aorta to look for a AAA, and looks at the lungs to see if there's a pneumothorax. One caveat is many of these protocols don't include looking at the uterus for women who are pregnant. And so please, especially if you're an emergency physician, always think about this, because this is faster than a urine HCG. I think the hardest test to get in the emergency department is a urine test. And if you can look with your ultrasound and see the pregnancy, obviously you can make decisions that will affect your resuscitation. Okay, so for cardiac, what are we looking for? There are really 4 things, and this has been, there's a consensus statement now between the American Society for Echocardiographers and the American College for Emergency Physicians. And these are the 4 things that everybody agreed are useful in a point-of-care ultrasound test. I can tell you, I was in those meetings, and those meetings were very contentious. There were not a lot of friendly faces at the beginning. But this is something that I think after discussing, people realize that this has an important outcome for patients. And so if we're really truly honest and we're thinking about the patients, these are very simple yes-no questions that we can answer with a point-of-care test. So just very quickly, this is not really a how-to test, but I just want to make sure you have the anatomy so that when we show you the pictures, you can see them. The subxiphoid is a view where the probe is in the right epigastric space, kind of shooting up through the edge of the liver, looking at the right ventricle and then the left. What you'll see on the ultrasound is the right ventricle at the top part of the screen and the left ventricle at the bottom part of the screen. When the pericardium, which is this white stripe here, is touching the myocardium and there's no space between those two, there's no pericardial effusion. The parasternal long, which is the second most important view, I think, in point-of-care ultrasound, is where you have the probe in a long axis view between the shoulder, the left shoulder here, and the right hip, and you're going along the long axis view of the heart. And what you'll see in that is you'll see kind of a slice from this angle. And that means that you'll see the right ventricle on the top of the screen. You'll see the aortic root here in the middle, the left atrium, and the left ventricle behind. And here you can see the descending thoracic aorta. This is very helpful because a pericardial effusion will cross the mediastinum above the descending thoracic aorta, while a left pleural effusion will taper to the descending thoracic aorta and stop. So it can be very helpful in deciding between those two. And then finally, the third view that I think is very helpful in point-of-care ultrasound is looking up the heart. And what you'll see there is you'll see the chambers side by side. So you'll see the right ventricle and the left ventricle side by side. And this is very helpful if you're trying to decide globally whether the right ventricle is larger than the left ventricle. So that was cardiac ultrasound in about 2 minutes. So now I'm going to show you some pictures, and we'll see if what you think. Okay. So the first case is an 80-year-old female. We know nothing about her history. She's tachycardic, pretty hypotensive, and mildly hypoxic. And you have this patient every day. I know you have this patient because I just saw them in the emergency department. And they're always almost hypotensive to be getting everyone in the room, but never quite hypotensive enough. And so usually you're in the room by yourself for a while. So you decide to do cardiac ultrasound. So what do you guys think? So remember I said if the pericardium is touching the myocardium, then there is no pericardial effusion. And here, there's an anechoic or black stripe surrounding the heart. Fluid is black in ultrasound. So this is a pericardial effusion. Now again, you have to think through whether this is the cause of her hypotension. Is she febrile? Does she have other causes of her hypotension? But certainly, this makes you much more interested in pericardial effusion and tamponade. And I don't know if you can appreciate, but here as the right ventricle is trying to relax in diastole, it's having some trouble. It it does this kind of wavy relaxation. And so this is somebody who you're going to think a little harder about giving fluid to. You're going to think a little harder about maybe draining that to see if you can improve her hemodynamics and maybe use ultrasound to help you drain that. And this is going to change the way you think about her resuscitation. What if you had this picture? So she's toxic and you have a very nice beating heart. The myocardium is touching the pericardium. Now you have to think about pneumonia. You have to think about other things, but certainly you're not thinking about doing a pericardiocentesis. So these pictures, 1 and 2, change the way you think about resuscitating this patient, and I think this happens more often than you can imagine. Pericardial effusion. So here, this is a very large, it's probably almost a liter of fluid, but you can see that the right ventricle is full in diastole. So this is probably someone with a long-standing pericardial effusion. Whereas this picture, again, the same almost liter of fluid, a lot of separation between the myocardium and pericardium, but this right ventricle is almost fully collapsed. So this is a much more emergent situation than the other one. And certainly very small pericardial effusions here are interesting to note, but maybe is not the cause of your hypotension and your shock, and so you move into the different parts of your algorithm as you think about it. Okay, so remember I said four things you're looking for. You're looking for beating heart, you're looking for pericardial effusion. Now you're thinking about global ejection fraction. So this same patient, instead, you look at her now with her heart and you see this. Do you think it's a good ejection fraction or a bad ejection fraction? So that's a Socratic method. But obviously this is a very poorly beating heart. And so instead of giving her a liter of fluid like I gave to the patient with the pericardial effusion, I'm going to think very long and hard before I give her too much fluid. Her left atrium is very enlarged. Her left ventricle is barely moving. She has a pleural effusion because it tapers to the descending thoracic aorta. It does not cross the descending thoracic aorta. And so she's in cardiogenic shock. So I think a very different way. I may start nitrites. I might think of agonists. I may think of many different things when I'm resuscitating her than I did the first patient. And just for contrast, if I see this in the peristernal long, nice healthy hearts, probably not this female, but just for contrast, you can see the difference between a well-beating heart and a poorly beating heart. Now, I've not spent more than 10 minutes teaching you this, and I think most of us, as clinicians and with our medical education, can make those extremes. I'm not here to tell you that you can be a cardiologist with this. Obviously, there's a lot of patients in the middle that are gray and require consultative echocardiography. But in a shock state, it's very helpful to know if the patient has a good heart or a bad heart. And I think that you can decide with your point-of-care test. Here's another patient. Point to the septum here. Everything seems to be shortening and contracting in the left ventricle except for that septum. So again, as you get used to looking at this, you can see that this wall is contracting well and this wall is not contracting well. And I can tell you in my hospital, I can do a cardiac ultrasound faster than my nurses can do a EKG, or I can do an EKG. So again, not that I'm not going to do EKG. I'll certainly want an EKG after seeing this, but this may change the way I prioritize what I do next. And so it's very helpful when you're, in a kind of stressful environment trying to decide the next test as you look at that. Okay, so our same patient, this poor woman has many, many problems. And now and this is the apical 4, and remember I said this is the really good view to see the right ventricle and the left ventricle side by side. Usually the right ventricle is smaller than the left ventricle. And so what do you see here? So this is a very big, it's bigger, right, than the left ventricle. Here the right ventricle is bigger. So in a woman with new hypoxia, new tachycardia, new hypotension, all of a sudden the first thing that comes to my mind is not necessarily pericardial effusion or sepsis. The first thing that comes to my mind is a PE. And you have to be careful. Obviously, this is not the only test you want to do, and you may need to have other tests, but it changes the priority of what you're doing in your resuscitation. And we had a case that looked just like this in a young female with a cast on her leg. And in those patients, the differential is very small. And when you see something like this, if they're near arrest or they're in shock, lysis comes to the forefront much quicker than it would have without this test. And this is another view. It's a little hard to see, but this is what's called a peristernal short. And you can see that the septum here is being pushed by the ventricle, which is another sign of right ventricular pressure. Okay. So again, this is not to make you into experts in one hour, but it's to suggest that with cardiac ultrasound in shock patients, you can really make a difference in how you think about them and your differential diagnosis. This is something, thoracic ultrasound is something that instantly can change your practice. And the reason for that is it's very, very easy to do. Cardiac ultrasound takes some time to learn, and it takes some skill. Thoracic ultrasound, my 10-year-old nephew can do. And the reason for it is it's very easy. You take the linear probe, you put it on the anterior chest where you're suspicious that the air would travel, and you look to see if the visceral and parietal pleura are touching. What that looks like on ultrasound is when the visceral and parietal pleura are touching, you can see this slip-sliding motion back and forth. Now, obviously, I'm only evaluating the pleura that's under the probe. So if the patient is upright, I'm going to spend a little more time looking in the apices. If the patient is supine, I'm going to spend a little more time looking in the anterior chest. If I just did a thoracentesis, I'm going to look where I just did a thoracentesis. But this is relatively easy to see, and you will get used to seeing this the more you look at it. And it's amazing. This has definitely decreased the number of portable chest x-rays that we do in our emergency department. And it's because it's a very good rule-out test. The difference is when the visceral pleura drops away, now there's air between the visceral and the parietal pleura. The only thing you see is the parietal pleura. It's a fixed line. And so instead of seeing this slip-sliding motion back and forth, you just see a fixed line like that. It's easier for people to rule out a pneumothorax than to rule in a pneumothorax. So obviously use caution in the beginning when you're doing this, because there are other things that can cause a fixed pleura. Adhesions, surgery, scarring, all those kinds of things. But there is nothing that mimics this. You have to have two pleura touching each other in order to see that slip-sliding motion. And there's many, many studies. These are just a few. But the power is in the negative predictive. There are very few tests that have near 100% negative predictive power, and I think that's what's so exciting about this as a replacement for X-ray when you're thinking about ruling out a pneumothorax. I know it seems like voodoo. I can see there's some people with some, not so sure looks on their face. But trust me, you just have to take a few looks and you will get this. This is nothing that is very difficult to learn. Okay, IVC ultrasound. This is also something that you can do in your resuscitation state. So again, now you've looked at the heart, you've looked for contractility, you've looked for an effusion, you've looked at the lungs to see if they're sliding. Now you take a look at the IVC, putting the ultrasound probe with the pointer to the head right here as the IVC travels behind the liver through the diaphragm and into the right side of the heart. What you're looking for, again, is not very subtle things. You're looking to see if the IVC is plethoric and big or if it's flat and the walls are touching. And again, it's not usually that subtle in the extremes. So if somebody has a PE or somebody has a big pericardial effusion, the IVC is going to be stuck wide open, and the next thing I would do after seeing that is to look at the heart. Whereas if the IVC is, almost doesn't matter what else is happening, they need fluid. And so you can start your fluid resuscitation almost immediately when you see a flat IVC, because the patient is so dehydrated that the walls of the IVC are touching during respirations. And so again, I think in the extremes, this can be very helpful. Obviously, when there's a middle ground, it maybe is not as helpful to do this test, but it takes you 2 seconds to look, and it can give you a much narrower differential for your patient. The other thing is when you see this, when you see a collapsed IVC and state, it takes also about 2 seconds to slide your probe to the right upper quadrant and to see if there's bleeding in Morrison's pouch. And this is very important, especially for young women. We use this a lot in our emergency department for people who come in who are worried about an ectopic. And seeing this flat IVC and fluid in the belly in a young woman who hasn't had trauma should make ectopic pregnancy the top 10 things on your differential. And so I think this can be very helpful. Young women can survive with pretty significant blood loss and normal vital signs for a long time. And they don't always present to the OB hospital. So just so you know, women don't always know that they're supposed to go to one hospital and not the other if they have an ectopic pregnancy. Okay, So the other thing, for those of you who work in trauma hospitals, is this is a very common call that we get in our emergency department at Mass General. People are very bad drivers in Boston, and so there's lots of motor vehicle accidents. And you'll get this call, and it usually makes everyone's blood pressure go up a little bit in the emergency department. And you're thinking about 4 things. You're thinking there could be blood around the heart, but I've already showed you how you can rule that out. You're thinking that there's blood in the chest or blood in the abdomen, or they're fine. And that's a very helpful thing in a shock state because it wastes time to do procedures or to do an operation that is not necessary. So it's, again, not very hard to do. When you're doing your fast exam looking in the right upper quadrant, this is your liver, this is your kidney. The thoracic spine above the diaphragm. The only reason the sound waves can travel through to the thoracic spine is because there's some fluid there that transmit the sound. So if I see the thoracic spine above the diaphragm, that patient has a pleural effusion or hemothorax. Whereas here, if there's a blood pocket separating the kidney and the liver below the diaphragm, then the bleeding is in the belly. Now, obviously, this is for extremes. These are the shock patients who come into the emergency department who need an operation. This is not the patient who has normal vital signs and may have a little tiny bit of blood around the liver. But what I'm telling the surgeons now is I'm saying instead of doing a chest tube, don't waste your time. There's no blood in the chest. Worry about the belly and go to the OR and do a laparotomy. Or instead of doing a laparotomy, let's not go up to the OR. Let's do a chest tube right now because I can see that the blood is in the chest. And that's a very, very time-effective, cost-effective, and patient-effective way to manage your trauma patients. Again, not that this is why you want to learn this, but it also gives you a sense of there's nothing better than telling a trauma surgeon what to do. So not that that's why we do it, but it can be very satisfying. Now, you have to be right, so you can't be wrong, and so you need to practice a little before you come off with that kind of confidence, but it's good. Okay, a few other things that you might see. So remember the RUSH protocol. You're looking at the heart, you're looking at the lungs, you're looking at the IVC. You're also looking for a AAA. And again, as you scan through here, this is the lumen. So you have to be careful that you set your depth. If you have a very big belly that you're looking at, don't set your depth at 10 centimeters. Set it at 20 centimeters or 25 centimeters. Because if you cut off your depth here, you would miss the entire AAA, which is the big calcified circumference right there with layers of clot inside. The other thing is not that this is what you're supposed to see, but here is the vertebral shadow as they fan through. I'll show you one more time. Right there. And so anytime the aorta is bigger than the vertebral shadow, it's bad. So you don't need to do lots of fancy calculations. The other thing is if you look very carefully right there, you can see there's a little black on top of the vertebral shadow. You don't always see that, but if you see that, that's also not good because that means there's leaking blood on top of the vertebral shadow, and this is somebody that's contained. They're a contained rupture, but they need an operation. And so that can obviously make a difference in how you think about your resuscitation. So what do you think this is? We're looking at an IJ. And you can see that there's something in the IJ. So again, not all of the applications are things that are life-saving or you get to tell the trauma surgeon what to do, but sometimes they're just things where you look and you think, oh, I'm not going to put my central line here, I'm going to put my central line over here. So they can be very basic things sometimes just to even see where the best place for a central line is. And it doesn't take a lot of training. I would suggest you don't need to compress here when you see this. Just leave it alone and go somewhere else. Just, this is the things that raise your blood pressure a little bit. And obviously there's not any reported cases of people pressing and causing stroke or causing PE if you do it in the legs, but you don't want to be the first one. So here's another picture. Again, this is to make my point before. This may be not something that you see all the time. This is the bladder. This is the uterus. This is some blood within the uterus, but this is not a normal-looking gestational sac. And I don't see a heartbeat. I don't see any fetal activity. And then if I look up here and see this positive fast, again, this is an operation. So the nice thing about ultrasound is you're really taking people who are unstable and you're calling your consultants and you're calling them with some definitive knowledge. There's nothing worse than calling a consultant and saying, I'm worried about this, And they say, well, why are you worried about this? And you have to go through all these physical exam findings or vital signs, and they still want more tests because, of course, they're going to have to disrupt their schedule to come down and see your patient in the emergency department. If I can send these pictures by my ultrasound and the digital pictures, and I can send it to them by email, we have a much better conversation. And it's a quicker conversation, it's a more professional conversation, and it's a conversation that helps the patient, most importantly. Okay, this is an awesome clip. I love this clip. So again, this is not usually what we do in terms of resuscitation. I'm going to tell you that we're looking at the neck. This is the thyroid. This is the trachea. And this is the resident putting the tracheal tube in the esophagus. So I can tell them, as I'm watching them, this is something you can do in real time. So you have to train people to intubate. And so you take the ultrasound, and this here's the esophagus, and here's the tracheal ring. The tracheal ring has cartilage. And as I'm watching, here's the trachea, something's happening over here. And again, in seconds, I can say, no, 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 you're in the wrong place, pull back, relook, and nobody is vented through the esophagus, nobody aspirates on this, nobody has trauma from their aspiration, and it's something you can do very cheaply with the same machine that you used all your other procedures for, and you can watch your intubations. Now, of course, there are expensive machines you can buy. You can buy VideoMax and all these other machines, but you know, you could look with the ultrasound, and if I show it to you again, here's the esophagus. You know, I think most of you now can see the trachea, and this is the esophagus going the wrong way. So again, not what we usually teach ultrasound for, but you can find all kinds of crazy uses for the machine once you have it in your department. Here's another case. And again, these are all cases from our emergency department. These are not cases that I'm like, you know, showing from the web or something like that. So again, this is an ultrasound that was done by one of our interns. They looked at this picture and they said, oh boy, that doesn't look good. And they don't know what it is. You know, they're like, you know, 2 days of being a doctor. They don't know. But they know that usually the heart doesn't have something bouncing around in the left atrium. So again, this is all of a sudden changes everything we do. Now we call cardiac surgery, we call interventional radiology, we call a whole bunch of different people than we were thinking of calling for this patient who came in with chest pain. This one's a little hard to see, so I'll show you this one instead. You know, again, not what you're using ultrasound for necessarily, but if you see something, say something. And so if you see what looks like a beating flap within the aorta, the other amazing thing is you could use this to decide if it's a type A or a type B. You look in the abdominal aorta, you see the flap. You look at the carotid. If you have a flap in your carotid, you know that the dissection has gone beyond the arch. And so instantly it changes whether you call the cardiac surgeon, you call the vascular surgeon, you do nothing. So it can be very, very helpful. So I just want to say there's some historical perspective. This was a quote from 1832 in Boston. So, you know, this is something that we're near and dear to our hearts in Boston. But like most new technology, there is a risk that new practitioners will make mistakes based on their erroneous interpretations. And that what comes after that is not a logical conclusion. This technology, therefore, must be restricted. I think what comes after the first sentence is that this technology must be taught. And so this is not something that you can do without education, without instruction, and without teaching. Of course, nobody expects you to use your stethoscope without teaching or instruction. But what you can do with this is you can use this technology in a way that helps to refine your diagnosis, to narrow your differential, and to improve your resuscitation so that you're using it in a smart way. And my favorite picture here is these are not all doctors. Some of these people are nursing assistants, some of these people are respiratory techs, some of these people are anesthesiologists, some of these people, and they're all using the stethoscope. And I think it's the exact same thing with the ultrasound machine, in that the ultrasound machine is not the property of one specialty or one group of people like physicians. This is something that nurses can use to place IVs. It's something that your pre-hospital team can use to decide where to bring the patient to. It's a lot of different people that can use this technology. And obviously, you need to use it in a defined way. You need to be trained to use it. You need to have a process for making sure that you're using it correctly, a quality assurance process. But this is not something to restrict because it has the potential to help people. So I think it's a very similar analogy. And I think all of us would say that now the stethoscope is fairly ubiquitous throughout the hospital. The other thing I will say is there are many places in the world, and not just in Africa, but in the United States, I'm sure in Brazil, where people have access to very limited diagnostic imaging. And so this is one of my favorite pictures. This is the radiology department at a clinic in Rwanda. And so he is a saint, honestly, he is a saint, because what he does is he takes the picture, he goes outside and hangs it on these little clotheslines, and 2 days later, someone gets some important information. It does help the patient, of course, to know this information, but there is such a huge gap between what we can provide with our technology and what is happening now. And, obviously there are economic reasons why this still happens, but the machines are getting cheaper and they're getting smaller. And so imagine if we have these machines and we can give them to these clinicians who are in these remote areas, who are far from a big hospital. They're not having huge renovations and all kinds of things happening in their hospital to make it bigger and better. They're working by themselves in these very remote areas. And I think that's where the potential for this technology also has a huge impact, because they can now all of a sudden diagnose things that they would have to tell their patients to walk days or drive days or fly days to get a diagnostic imaging test. And that's it. That's the end. And I don't know, I'm sure people have questions. I'm happy to take questions. Yeah.
Márcio, eu hoje fui procurar a data que foi o primeiro estetoscópio utilizado, 1816. 200 anos depois, será que a gente está enterrando o estetoscópio? E estamos iniciando uma nova tecnologia? Mas eu acho que é uma área do conhecimento que está se fazendo necessária em algumas áreas críticas, e especialmente na entrada da emergência. Alguma pergunta? Please, Dr. Antonio.
Hello, I'm Antonio. I work in the emergency room, like Marcio and Ana. It's quite easy to check to see the pulse in femoral artery, for example, when we are searching for a how can I say, deep thrombo in the leg. What about using that to check the pulse during resuscitation? Would it be nice? Do we have a place for that?
Yeah. So I think the question was, can you use the ultrasound to check for pulse in the femoral region the same way you can look for cardiac contractility in resuscitation? And absolutely. I think one of the challenges is, how much you're going to look for and how much you have to do during resuscitation. So depending how many people you have in the room, absolutely someone could look at the femoral artery to see if it's pulsing. I'll tell you that you can get fooled with looking for the femoral artery also, because if the pressure is very low, if the pressure is 60 over 40 or 50 over 40, you're going to have a hard time seeing the pulsations, but you can see the ventricle contract. So sometimes I think it's a little bit easier to see the ventricular contractions than to spend time trying to decide if the artery is pulsating or not. But you can also use color Doppler or pulse Doppler. Many of the machines have those standard now on their machine. So using that to check for flow is also very nice. I have to say, one of the reasons why I never let the residents do femoral lines anymore without it is because the reason why we have so many femoral A lines, I think, is because during resuscitations, is because you don't realize that you're feeling the artery and not the vein. So you're putting the line there. But absolutely, you could do that.
Oh, yes. Well, first of all, thank you for your talk. It was brilliant. We are in a teaching hospital, so I wonder whether you have like a structure course for different levels, like students, medical residents, multidisciplinary professionals. We'll see in your last picture most of the with the stethoscope. How would you tell us how to organize courses or different levels of training to get our students and residents and nurses and techs to different steps in really getting able to do rapids and quickly and help the decision team? How would you tell us to do that?
Yeah, that's the most important part. So there are a few ways to do it. There's a couple different strategies. One strategy is to have people like Marcio and Anna and Bianca on staff who can help you organize these courses. And it's very, very lonely if you have one person doing all the teaching. So I think having a team is really nice. The main thing, I think, is to make it part of the normal training. So when you have, nurses that are coming on staff, the first thing, or not the first, I mean, maybe they should learn how to take vitals or something, but one of the first things is that you incorporate this into their orientation so that they see the machine and they learn their specific part, which is how to place a peripheral IV. Same thing with the residents. I think as you bring in the residents, part of their orientation is that they think about the ultrasound machine for a resuscitation. And you learn, in the beginning, I think it's important to focus the applications on things that are learnable, like pneumothorax, that are teachable, and then you can grow step by step. Then by the end, you can look at other things. I think the hardest people to teach, honestly, are the multidisciplinary staff, because in my hospital, it's the same. And the problem is, of course, people have been practicing for 20, 25 years, not using ultrasound. They say, I'm a fine doctor without this, thank you. But yeah, and I get it. I totally understand. I think what happens is that the residents and the students who are very technology friendly pick this up in 2 seconds, because it's a video game. The students who I teach at the medical school, they don't even need to know how to use the buttons because they figure it out. They say you play around with it, and 2 minutes later they know how to use the machine. So it's a very different mindset. And then the supervising doctors get pushed because they come on the wards and they say, why are you ordering a chest X-ray? I can do the ultrasound. And, So I think in the beginning, making it part of the training and focusing it on a few applications. If there's too many things in the beginning, I think people feel overwhelmed. And you want to also have, and Marcio can speak to this as well, but I think it's important to have a quality assurance process so that the images then teach other doctors. And what we do is once a week, we take a case from the emergency department and we send it to the entire staff and say, this was an interesting case, maybe it went well, maybe it didn't go well, why were the images used, why were they not used, and just reminding people of the machine, I think sometimes can help. But it takes time, and even with the ACEP guidelines, which are only 150 exams, for the practicing clinician, that's a lot of effort, and so it can be a little painful on that end. But I think for the students and for the residents, it's a very natural extension of what they're already doing in the iPhone. They can use the iPhone to look at the pictures and teach them.
Just one more comment on that is that when we were last year, we were able to participate on the first World Congress on bedside ultrasound in medical school. So the University of Columbia, United States, they invited everyone to talk about how to teach ultrasound for medical students. And they do have some research showing that they improved and they get really good on ultrasound very, very fast.
I'm Marco Torres. I'm professor of medicine at cardiology, and it sounds like music you lecture today for me, and I'm sure for all people in the audience. Although I agree completely with you in terms of the importance to teaching students, residents, and so on, sometimes this strategy looks like that phrase about Churchill, mind, in which he said that sometimes we have to look at the results at the same time like we are looking to the strategy. And it will be a very long time to get the results. So what would be the bypass way to give the people that are in the emergence, I mean, talking about registered nurses also, what would be the best way in your mind? What would be your do it like I do? So how would you tell us how to begin this in the everyday practice?
Well, I think I don't know if it's the same in Brazil, but in the United States, when we first started using ultrasound, it was there were some people that were not supportive, and there can be the people you imagine. You know, the radiologists looked at our training guidelines and thought we were crazy. The cardiologists looked at our training guidelines and thought we were crazy. So what we did, and again, this is a secret, so you can't tell anyone, but what we did was we used it first for procedures. Because procedures, no one can argue that using something to look at the structure you're trying to poke with a needle is better than just, you know, feeling and guessing. And once you have the machine, once the machine is in the department and you have the machine that can be used for IV and can be used for central lines and can be used for paracentesis, can be used for thoracentesis, can be used to look for abscess and draining abscess or joints, those things are hard to argue from anybody. And so once you have the machine, then growing it to the diagnostic piece, I think is a much easier growth, and it's less contentious, I guess is the right word. I think the other thing is that you can't, once you put the machine in the department, I will tell you, no matter what your rules and regulations are, someone will use it for something that is not in the rules and regulations. So, and that's okay, because I think sometimes it's pushing the diagnosis and it's pushing the use, but you have to be aware of that, because it's exactly like you said, you're doing the strategy at the same time as you're doing the learning. And so you need to make sure that there are safety valves. So there are ways for people to review the images, or to save the images, or to use the images for teaching. But I think until the machine is in the department, it's all very academic. You have to have it there to start using it. The other strategy we use a lot for the ICU is we have the machine come on the rounds with the team. And so you're at the bedside, the physician is talking about CVP, they're talking about wedge pressure, they're talking about this, they're talking about that. Then you take the machine and you put the ultrasound on the heart, and you see a big dilated LA, or you see a very big atrium, and all of a sudden it clicks in the mind of all the students because you can see it at the bedside. So I think for the wards and for internal medicine, just making sure the machine is accessible and available for the teaching rounds is helpful. And it grows, you know, faster than you have a strategy for anyway.
Okay. Nenhuma pergunta? I would like to say many thanks to Dr. Vicki to stay with us. Nós passamos para terminar esse Grand Round e lembrá-los que na próxima quarta-feira nós gostaríamos de ter uma presença maciça de todos os alunos, professores, enfim, todos envolvidos aqui com o hospital. E nós teremos a presença do professor Divisão discutindo ensino médico. Muito obrigado e até a quarta-feira que vem.